1 second.
Welcome, everyone. Thank you for joining us today for this third annual Women in Medicine Transforming Healthcare Lecture. I'm Dr. Nicole Sandhu. I'm an internist at the Mayo Clinic in Rochester, Minnesota, a past president of the American Medical Women's Association, and chair of the AMWA Leadership Council. We're gathering today during Women in Medicine Month to honor women physicians, promote the history of their contributions, and to inspire physicians in training, and those interested in becoming physicians. This lecture series is a collaboration of the Women in Medicine Legacy Foundation and the American Medical Women's Association, and today's panel discussion is about leadership. The mission of the Women in Medicine Legacy Foundation is to preserve and promote the history of women in medicine for the purpose of impacting the present and future of healthcare and the profession for women. The mission of AMWA is to advance women in medicine, advocate for equity, and to ensure excellence in healthcare. Both organizations clearly see the special role that women in medicine have had and continue to have in transforming healthcare. Before we begin, I would like to thank those who made this lecture series possible. The Leadership Council of the American Medical Women's Association, Gabby Benson, Executive Director of the Women in Medicine Legacy Foundation, the Foundation Board of Directors, Eliza Low-Chin, MD, MPH, Executive Director of the American Medical Women's Association, and Connie Newman, MD, member of the Board of Directors of the Women in Medicine Legacy Foundation, and past president of AMWA. I would also like to thank our sponsors, Dr. Paul Kirchgraber and Dr. Teresa Rohr-Kirchgraber, Dr. Danielle Larac Arena and Dr. Luigi Arena, Dr. Sam McBride and Dr. Eileen Barrett, Dr. Connie Newman, Dr. Laura Roebuck and Dr. William Meehan, Millionaires, Dr. Douglas Chin and Dr. Eliza Low-Chin, and the AMWA Leadership Council. Our in-kind partners we would also like to thank, and they are the American College of Physicians, the Arkansas Medical Society, the Association of Women Surgeons, Executive Leadership in Academic Medicine, Medical Women's International Association, and Obesity Medicine Association. We have two accomplished and distinguished physicians to speak with us today on the topic of leadership, Dr. Rana Awdish and Dr. Jessi Gold. The moderator of our discussion, Dr. Sue Hingle, is also a distinguished physician, an internal medicine specialist and professor of medicine, who serves as the Associate Dean for Human and Organizational Potential, Chair of the Department of Medical Humanities, and Director of Faculty Development at Southern Illinois University School of Medicine. Dr. Hingle is also the current president of AMWA. I'd like to hand things over to Dr. Hingle at this time.
Thank you so much, Dr. Sandhu. I am so excited to be here with all of you. It's a great opportunity not only to spotlight Dr. Awdish and Dr. Gold, but also a wonderful time, since it's Women in Medicine Month, to really celebrate all of you and to celebrate really the power and potential of women in medicine and science. And we're very excited for this evening. So I'm going to first introduce our speakers, our panelists. I think we're doing this alphabetically, so I'll start with Dr. Rana Awdish. She is the author of a book called In Shock. It's a critically acclaimed best-selling memoir that's based on her own critical illness. She has received the prestigious Schwartz Center National Compassionate Caregiver of the Year Award in 2017. She was named a healthcare hero by the U.S. News and World Report in 2020 for her pandemic work. She is a practicing pulmonary critical care physician. She also serves as the director of the pulmonary hypertension program at Henry Ford Hospital and the medical director of care experience for the system, where she has integrated compassionate communication strategies as well as narrative medicine practices into the curriculum. She has had her work published in many, many venues. I could go on and on. I will name a couple of them: the Examine Life Journal, Chess, the New England Journal of Medicine, Harvard Business Review, Annals of Internal Medicine, Washington Post. She had an essay titled The Shape of the Shore that was awarded a Sydney by the New York Times and nominated for a Pushcart Prize. She completed her training at Mount Sinai Beth Israel in Manhattan. She attended Wayne State University Medical School, which, by the way, my father attended. and she completed her undergraduate degree at the University of Michigan in Ann Arbor. Next, I will introduce Dr. Jessi Gold. She is board certified in psychiatry. She is the Chief Wellness Officer at the University of Tennessee system. And you can see the wonderful trees in her background that she said is because she lives in Tennessee. She's an associate professor in the Department of Psychiatry there. And in her clinical practice, she sees healthcare workers, trainees, as well as young adults in college. She is described as a fierce mental health advocate, a highly sought after expert in the media on everything from burnout to celebrity self-disclosure. She too has written widely in the popular press, also including the New York Times, The Atlantic, Slate, as well as Self. And very excitingly, she has her first book being published. It is called, as you see on the screen, How Do You Feel? One Doctor's Search for Humanity in Medicine. Excuse me, and it comes out October 8th. It is being published from Simon Element and is currently available for pre-order. I think they'll put the information in the chat for y'all. She graduated from University of Pennsylvania with a degree in anthropology, the Yale School of Medicine, and the Stanford University Department of Psychiatry. And reading through these bios, I am starting to get a little bit of imposter phenomenon. But I am so honored and humbled and really excited to be here with both of you tonight. So thank you so much for joining us.
Thanks for having us.
So I know we had some questions we were going to talk about. I'm going to flip to the first two, because when I was reading through these, I was thinking about, wow, we really need to create psychological safety. And I'm going to just jump right in and say, tell us about your personal experience. So let's flip a little bit, and we'll start with the second question. So as physicians, we are often discouraged from self-disclosing by sharing our stories with others, whether that be our colleagues, our learners, our patients. So tell us, both of you in your books you do a lot of self-disclosure. So can you tell us a little bit about how you came to the decision to do that? Like how did you get there mentally?
You want me to go first? I see that look. Okay. Self-disclosure is interesting. There's a part of me that's always wanted to self-disclose and been just sort of an inherently authentic human. But then there's the part of me that went through medical school and was told not to. And then the part of me that went through psychiatry training and was told extra not to, because psychiatry has kind of long had this old school Freudian belief that we're supposed to be a mirror that just reflects, and you would be taught not to put pictures of your kids in your office. You'd be taught not to talk about yourself at all. So it's not messing up the patient encounter, which is kind of how you were told. And so whatever I thought, I definitely learned differently. And I think that was in my head for a while, especially as a trainee. But I learned pretty early on that my experiences in sharing my, whatever I was going through as a med student or as a resident led to a lot more conversation and change than just talking about the topic. So I had an experience in medical school where I was basically tricked into performing cardiac massage on a patient who was already dead. And I had a lot of feelings and reactions towards it and didn't really know what to do with them, and turned to writing, and was encouraged by mentors to then take that further and publish it in Annals of Internal Medicine. And it was the first time that I did something where I got positive feedback, which doesn't happen in medicine, but also felt like it gave me a different kind of voice that I felt really trapped as a student to not really do much about that attending. And even the dean said something like, that's just what he does. And so I felt like with writing, I found a new avenue for advocacy where it didn't matter what stage of training I was in, but like my story could change stuff. And as I evolved in training and as I evolved in what I learned about myself and patients, so did my writing. I think social media also contributed to that for me. So I've always talked about being a person who goes to therapy on social media, but it did take me longer to talk about being on meds. And I think that was a product of the same sort of stigma that comes with being in healthcare. And I had to kind of break it down myself, despite being someone who prescribes. And I think really decided it was worth it to talk about it, because when we talk about it, we normalize it. When we talk about it, we can change culture and the conversation. And I think as a psychiatrist who sees healthcare workers, I felt like it was right for me to talk about it. I don't think everybody needs to, but I do think in the position I'm in with the population that I see, I have a unique perspective to really help by talking about my own experiences. And so have decided to do that. And the book is way, way, way more of that than I probably have ever done. And so like vulnerability for me on that is on like 100, but I feel good about what I ended up with, I think.
Yeah, a little bit exciting and scary at the same time.
Yeah, like anything vulnerable, I think.
Yeah. How
Yeah, and
about
I
you,
think
Rana?
that vulnerability piece was key for me. It's interesting to reconstruct it retrospectively because now we know how it turned out, but I know I felt very worried when I was disclosing the communication errors that I saw in the medical system, the gaps in care, the discoordination, the lack of empathy. It felt like talking about family secrets outside of the family, and I didn't know how it would be received. What I think gave me courage to do it was that it was such a revealing time for me that I saw so many things that had been right beneath the surface when I was a physician that I didn't see, that I knew if I felt this way, my patients felt this way, a million times over. And they didn't have necessarily an understanding of our culture, our norms, the reasons we behave this way. And they also didn't have the power necessarily to give voice to it in a way that it might be heard. And so leveraging my physician identity a little bit to tell my patient story was a way to give voice to stories that might not otherwise be heard. And whatever consequences there were for me, I think I was able to accept them, understanding that any consequences for my patients would be far more difficult to endure, given that I was in a position of relative power. The gift of that vulnerability, though, was such a lesson because, like any story that lives inside of you, you think you're the only one who's ever felt this way. You think you're the only person who thinks about it this way until you externalize it and can have other people say, gosh, I'd been feeling something like that because of this thing that happened, and I didn't have the words for it, but I see myself reflected back. And then you start to build community and I think affect real change. So it's been incredibly rewarding, but I won't lie that it wasn't scary.
So you both talked a little bit about sort of the system. Your book, Rena, talked a lot about really personal experience. And from what I understand, Jessi, yours does as well. I have not, obviously, since it hasn't come out yet, I haven't had the opportunity to read it. But let's get personal here. And can you talk about how your personal experiences really shaped your understanding of the doctor-patient relationship? So, the dyad, as well as the practice of medicine. So take it from the system level into the room.
Sure. Are we going in the same order?
Why not?
Okay, I just saw you looking at me, Rena, like, hey, I think, for me, the story that I talk about in the book, the experience that I'm talking about takes place during COVID. COVID is a setting of, compounding stressors, not a setting that is the only setting and the only time that this could have happened. But I do think that for me as a psychiatrist who sees healthcare workers, who's single and was by themselves, it was a pretty perfect storm of things to cause burnout. You know, ironically or not, I think a lot of what I talk about is how I became a burnout expert. And at the same time couldn't identify it in myself. And I think the reason I talk about that and the reason I think that's important is because if I talk about it all day, I talk about the definition, I talk about the signs and symptoms, I run around telling everybody about it. But my first reaction is either, I'm pretty sure that this is how you're supposed to feel in medicine, I'm pretty sure I can handle this on my own, or I'm pretty sure this is a physical illness. That's not good, right? That means that everybody feels like that, because if anybody's going to identify burnout or decide they need to treat it or ask for help, you would hope it would be the psychiatrist that specializes in it, at least as sort of an example of practicing what we preach in some capacity, though we're all quite bad at that. And so I think for me, you know, deciding to tell my story in that sense, but also in parallel, because in my book, there's also 4 patients that are in healthcare, and you can see kind of what goes through my mind when I'm seeing patients and how different things about patients might kind of ignite things for me or make me think differently about what I'm experiencing or make me sort of ruminate about something I previously experienced. And I think we learn so much from patients in ways that we don't necessarily even think about, because, you know, every day we see a lot of patients and don't pause and go, what's in my brain at that time? And I think in writing the book and reflecting on that, I realized like how much I think about those things and how much patient experiences inform my own experiences and my own sort of understanding of myself. And, you know, I think in talking about all of that, I realized like medical culture has a lot of barriers, right? Because if I can't identify it, nobody probably can identify it. And that's coming from a culture that has stigma, a culture that doesn't promote help seeking, a culture that values perfectionism and overwork and all of these things. And so I think for me, you know, the system itself is that, you know, as much as it is the things causing the overwork and the things causing the burnout, which is very system wide, I think it's also the culture that we kind of learn and that in training, and it makes us less likely to ask for help, less likely to notice we need it. And I tell my story and my patient stories for that reason.
The things that I saw on a system level kind of fell into 3 different buckets. One was just not really feeling seen as a person. You know, the obstetrical resident who asked for help interpreting my ultrasound images while I was actively dying and abrupting the pregnancy. That was one of those moments where I was really struck that he was viewing this as a clinical case and couldn't see my suffering. The language that we use around patients when we're just talking to our colleagues, hearing the anesthesiologist say, we're losing her, she's circling the drain, or the rounding team say she's trying to die on us. I recognized myself in those words. I had said them. I just didn't understand how it would feel to have them land on you as a patient and how they might impact your own sense of your ability to recover. And then the third thing was really how we're so trained to think that all questions are a request for data. So when I had an arrest in the SICU and was coded, and the code team was going to leave, and I'm asking, you know, can we talk about what just happened? They wanted to talk about the pleural effusion and the renal failure. And that wasn't what I was asking. As a patient, I was really saying, it's terrifying to me that I keep dying and like no one's talking about it. Could we maybe talk about it? Because it seems pretty obvious. And I think that is something we're less well trained to do. We're not trained to decode the emotions behind the questions, to see the fear and know how to respond. And that was really where I wanted to affect change, because I saw that I had some physicians who were very willing to attend to the suffering And that alone felt healing. And I had others who just saw the CAT scan in the labs and were going to tell me the results, and that was it. And that felt transactional. And I knew that the kind of doctor I wanted to be, if I was ever able to go back, had to be relational. It had to be able to decode the questions, to respond with empathy, and really hold someone's suffering, even if I couldn't make it better.
So we talk a lot about the hidden curriculum, and that's huge. Part of the hidden curriculum that we've alluded to is the culture of silence and the not help seeking. I'd like to dig a little bit more into what you were just talking about, Rana, the culture that generally suppresses the emotions rather than lets us experience those emotions. And you said there are some people willing to talk about this, but there's still a lot that are not willing to do that. And that hidden curriculum has such a strong impact. Currently, a lot of times negatively, but a lot of potential. So how can we start to sort of change that hidden curriculum where it embraces the emotional elements? Which probably, I mean, when you think about it, when you think about people wanting to go into medicine, they want to help people. And when you talk to students early in their careers, to them, it is the emotional piece. It's not necessarily the saving of lives and all of that. So any thoughts on how do we sort of change that, sort of uncover that piece of the hidden curriculum? Because I don't think it's talked about enough.
You want me to go again? I see you. Okay. I was thinking she said your name, so you would go. So for me, I think, we talk a lot about the empathy decline in med school. We talk a lot about like you said people come in to help people, but they also are stacked up against each other, right? So as much as you want to help people, you also don't want to lose, because you're a perfectionist who thinks that for some way, if you just studied more, you would never burn out, or you would never get ill, or you would never have a weakness. And weaknesses are taught to be something that is like something to be preyed upon, something we will lose a competition towards. Like we will not get into a residency program over someone else if we have feelings, or we will hear people say, if somebody, seems more emotional, like what's wrong with that person, either a patient or like a co-trainee or a colleague, right? And so what you learn is, I don't want to be identified by that. If I'm identified by that, I might lose in a competition, and it makes me imperfect, which is not something any of us like. And I think in a lot of ways, the way we change it is to talk about it. I think both of us believe that pretty strongly, because I think, not everyone needs to have a near-death experience or talk about their burnout or being on meds. I don't think we need everyone to be doing that. I think it's good to have some of us doing that. But what I think we need us to do is like say the quiet stuff out loud. Right. So we have a lot of times where what we do is weird or hard, or work-life balance is hard. And we don't even say that. We don't say like, it must be really hard having a newborn and coming to work, or, it must mean like, it must be hard to go from a code to eating lunch. Like we don't even go, this is weird. We just eat lunch. Right. And so there are lots of times where we just miss opportunities to have sort of open, naming it conversations with people that could really subtly and specifically change the way that we're learning about these things, and kind of counter that hidden curriculum, right? Like asking people how they feel when they see patients, and what that patient made them feel, what a code made them feel, what a M&M made them feel, right? We spend this whole time going through what you did wrong, but you don't ask the person what it was like for that to happen. So there are all these times where just subtly putting that in and asking people makes a difference. I think in psychiatry we try, because in a lot of ways, our emotions do impact like patient care and how it's received and what we're, you know, countertransference wise, meaning like what I'm getting from patients can impact how I'm treating them just because I don't even realize it. Like a patient makes me mad, a patient makes me annoyed, but we're not the only people who have countertransference, and we're not the only people who have feelings. And so I do hope that, you know, encouraging it through subtle sort of changes in the conversation can make a big difference, as much as us writing about these things can too.
Yeah, I agree. And I would add that, you know, what was modeled when I was in training was this idea that feelings were dangerous and that if you let yourself feel them, they would displace rational thought and your physician mentality and your ability to be in your cognitive mind, because you would enter your body, which I think is a scary place sometimes for physicians. And what that did really was suggest that these were just fixed objects. These feelings couldn't change based on how we interacted with them, and they couldn't transform into something else. We didn't trust ourselves, it seemed, to grieve. We didn't trust ourselves to feel losses or to feel guilt or shame, because it just was portrayed as something that would overwhelm us, and then we couldn't do the doctoring thing. And so what I've tried to model with my trainees, with my colleagues, with my teams, is naming the emotion, naming what's hard, just as Jessi said, and creating spaces. And the spaces look like lots of different things, but spaces to work with those feelings. During COVID, which we had a terrible first wave in Detroit, our clinical teams would partner with a clinical psychologist for peer processing sessions where we would just talk about what was hard that day. And hearing other people share what was hard for them and their struggles was so helpful, because even though they might not have felt like they did anything for the patient, we could so clearly see what values they were bringing to bear in that moment. And we could reflect it back to them and even see ourselves in those scenarios. And that, to me, is one of the things we can always do for each other. So if I have a colleague that is, you know, compulsively dissecting a case that went badly because they're just sure they missed something, I can say, you are such a thoughtful, comprehensive physician. It's so incredible how you look for these errors because you don't want to make them again. That is such a testament to who you are, that you have this growth mindset. It can help people see themselves in moments that I think can feel despairing, just differently.
I'm going to take a question from the chat and bring it in because it relates to what I think you were just very eloquently describing. And I'm not sure, well, actually, I'm pretty sure that most institutions don't have a Dr. Awdish to do what you do for your colleagues. So the question is from Natalie Walton, and she asks, are there any programs that have this structured intervention for providers to just talk about it, that she's been thinking about it? So I'd love for the two of you to perhaps talk about what are some of the things that there is perhaps at least structure around, and probably evidence as well.
So places call these Schwartz rounds, like that's where that came from. So they're structured conversations around cases that have a lot of these type of topics. Rana can probably tell you a lot more about it because I know she I think she leads them, but she definitely goes to them. But a lot of places have tried that as interventions, and that has been successful. I think that, yeah, the Susan Nuss mentioned Ballant groups, those are similar. You know, in psychiatry residency, we do process groups with trainees. So like when I was in training every year with my group of residents, every week we had like basically monitored group psychotherapy to process what we were doing in residency. It's probably deeper than most people need, but I think made a really big difference. I think it doesn't always have to be as structured, and that it can be helpful to find places for this anyway. I'm also a big fan of individual processing as much as I am for group processing. So I do think that we also often view psychotherapy as something that you do when you have an issue, like a problem, and the problem needs to be solved by the therapist. But I think that for me, it's a place to process work and to always have once a week to go to process work. And I'm not in a crisis actively right now, but it makes me better at my job. And I don't think we always think about it that way. I think some people view coaches in the same way, but I do think it's helpful to have a non-friend, non-family member, someone else also help you process stuff. So groups give you like normalization and perspective and sort of help you understand you're not alone. An individual might notice some stuff specifically to you and help you work on you, right? So that's how I view it differently. But I think a lot of those things are kind of starting to grow because they are helpful for folks.
Yes, and Schwartz Rounds is one of those venues that I think is an incredible equalizer where everyone admits, the case that got me up at night, and you see your peers reflected in your own feelings backwards, your feelings reflected in your peers. Our program, we're very fortunate to have a wonderful wellness officer named Dr. Lisa McLean, who's also a psychiatrist. And the program that she drew off of, I believe, was started outside of our organization called a Trust Partner Program. And that pairs individuals one-on-one when there's any sort of sentinel event that might cause trauma. So if you're presenting at an M&M, you get an invitation. A peer will be matched with you. It'll be a non-judgmental coaching conversation, just like we had in those peer processing sessions. We go through training to become trust partners. That's a great starting point because you don't need a lot of people to get that off the ground. The peer processing sessions were a heavy lift that I think we were able to do because so many people were sidelined in that first wave. They had the ability to kind of care for those of us who were in the hospital.
Thank you. So thinking about that more and more women are entering medical school. I mean, we're still seeing drop-offs and we still see significant differences in leadership, though we're starting to inch. How do you see gender playing into all of this?
Oh, so much. I mean, just like medicine is a culture, like our gender is a culture too, right? So we come into med school with a belief about mental health and feelings that is born from our upbringing, that is born from what we see in television and read in the newspaper. And so we have a concept that's already coming from a culture, right? And that culture tells us lots about gender and emotions, right? We learn that being emotional isn't good, and that looks like we are, I'm going to put it in quotes because I don't love the word crazy, right? And being crazy will get in the way. It will make us not good leaders too, right? So we've seen that play out when people run for things that are women, right? Like this fear that our emotions are going to take over and we can't do our jobs. And I think that's a view of women in leadership. So women in leadership tend to try really hard to be pretty stoic. And what we end up with is a lot of hidden anger, and maybe sometimes not hidden anger, because we can't like have no emotions as humans. It's just not possible. I think probably men have more emotions than they talk about. So I wouldn't want to tell you that women are just inherently more emotional, but I think that the belief is that we are, right? And that belief makes it hard because even growing up, if we like started crying, someone would be like, you're okay. They're not going to just like let us cry, right? Because that's not what we're supposed to do. We're supposed to stop the feeling. Big feelings are scary. And big feelings have always scared me. I've always been like, I feel sad. I want that to stop. How can I make that stop? As opposed to like, I feel sad. I'll just be sad for a while. Right. And I think that that is a product of gender just as much as it is a product of medicine for me and for all of us, that like, oh no, don't feel that. Or, oh no, make it go away, because you don't want to be judged for it, or you don't want someone to say you can't be a leader because of it. And so I think we have like an over control of our emotions because of that.
And, my experience of entering medicine was really one of wanting to acculturate to what I saw as the model physician, which was white, cisgendered, male, usually, heteronormative. Just that was the model. And as someone who wanted to belong, I don't think I separated out what are the attributes that will actually serve me in becoming a better physician, and what are the attributes that are actually not super functional, that are not something I should aspire to. I just thought, this is the model. The closer I get to it, the more of a real physician I am. And I really had to unpack all of that when I saw how many of the traditionally female ascribed attributes were actually so healing and so useful. The close listening, the willingness to be with suffering, the attending to emotions. And Suzanne Coven, to plug another female physician writer, wrote about this beautifully in her book, Letter to a Young Female Physician. She describes that it wasn't enough for her to become a doctor. She almost wanted to become a male doctor, because that was what felt real and true and strong to her. And that's a tough mold to break, but I think we're doing it because more and more we're recognizing that we were kind of gaslit, that these things that we bring with us that we want to embody were somehow negative when they never were. They just weren't part of the traditional culture, and we're shifting it.
Yeah. Yeah. Not kind of gaslit, totally gaslit.
I don't know the technical definition, and there's a psychiatrist on the phone. So
Yeah, it's interesting because there was a time when, and I kind of talk about this some in the book, like where I was told something that for sure was a subjective comment in med school, that really hurt me. And I thought, like, as a result of being told that, I needed to change my personality. And now when people say stuff like that, I realize that actually that personality is what makes me successful. But when you're young, you sort of go, well, they said I wouldn't be a good leader or doctor if I'm like this, so it's got to go away. And then if it comes back, you're lucky because you did the work or whatever, but it really tries to take it away from you.
So that's a good segue into probably our last question before there's lots of good discussion elements coming up in the chat and the Q&A. So how have you two been able to stay yourselves while doing this? And I guess that there's a presumption there. And maybe you lost yourselves and found yourselves again, or maybe you did lose important parts of yourselves, but sort of how do you respond to all of that?
I'm a constant work in progress. I think anyone who doesn't say that is probably not as self-aware. I think that I assume I will burn out again. I assume I will struggle again. I assume that I will need help on something again. And I've learned to approach life that way now. I think that that's the maturity, but also sort of things I've learned from bad things happening and hard things happening and having an awareness of that. Therapy has helped me for sure. And I'm always going to shout out my therapist. My book is an entire thank you note to my therapist in many ways. So I think that she deserves it. But, I think friends have been great for me. Like Rena's one of my close friends, and someone, you asked how we met earlier, and we met on the internet, right? Like social media, especially during the pandemic, was clearly helpful for healthcare workers. It was a place to share experiences and be validated by them, but it was also a place to share information and a place to feel connection when you were wearing masks going to work and no one else was, right? So it was a weird experience that you didn't have people to share it with, and social really did help with that. And I've made great friends from that. And I think people that have been friends in those situations are true, authentic friends that will like tell you like it is, and at the same respect, like really help you through hard stuff. And I think all of us need friends like that. And I think women are traditionally pretty good at that. If we're having a, we turn to friends, and I have had great women mentors slash sponsor slash friends. Like my med school mentor is one of my closest friends now, and it evolved over time because we weren't like boundaries, in med school. Like, so it has changed. And I think it's really important. And that helps me stay me too, because if I say something that doesn't quite line up, they can say something like, hey, that doesn't sound like you, or I'm not really sure that that is like coming from the correct place, or you're being pretty perfectionisty about that, or pretty overachieving about that. Like, you should be happy. So Rena's really good about like sort of level setting with book for me, because it's very hard to not feel like if you work on something for 3 years that it should have objective measures of success. And Rena's like, you wrote a book, you wrote a book, you wrote a book, right? And that's really helpful for me, because I need someone to do that, because otherwise you can get really caught up in a review, or you can get really caught up in the numbers. And that's not really, you didn't write it for that. And so it's helpful to have friends kind of put you back in your human form as much as they can.
I'm glad I can be that for you. One of the pernicious things about our medical training is that it eliminates time for the things that kept you whole for a long period of time. So residency, fellowship, even medical school to a certain extent, you just don't have space to keep those things integrated into your life. And to build them back when everyone's telling you you should spend every minute in academic achievement and doing research and mentoring and whatever writing is necessary for your career advancement is difficult, because it's not the value system that medicine sets up for us. So the most important tool, honestly, that I've found and that I try to teach in some of our physician identity work is attunement. Learning to listen and feel how your body responds in each moment throughout the day, because what lights you up might not be the thing that you thought you were going to value. If everyone thinks the cool thing is becoming an interventional cardiologist, but as soon as you put the lead on, you're like, oh, when can I take it off? I don't want to be here. This is taking forever. I can't get access. Maybe it doesn't make your heart sing. And maybe when you're sitting at a bedside educating a patient so they can self-manage their disease state, you feel alive, or working at the community clinic. But because there's so much prestige in medicine, we almost have to recalibrate to our own heart and learn to follow it to really create a career that will nourish us and allow us to have longevity. When I switched into writing, my mentor thought it was an absolute waste of time, that I should be running the ECMO program, that I understood hemodynamics. How could I not be doing that? And I had to trust myself enough to say, I don't think that will make me happy. And it's hard, right? When someone that you esteem sees you in a certain way. But our goals change. And if we attune to it, we're much more likely to build a career that will bring us joy.
Thank you so much. That's another huge part of the hidden curriculum. It's crazy.
It is.
Yeah. So
They tell you not to pee, right? Like you literally ignore your body, right? Like at the most simple physical thing, you literally learn to ignore hunger and bathroom. So if you ignore hunger and bathroom, why would you have an emotion? Or why would you know that a physical sensation is a reaction to something you hate or something you don't want to be doing? You literally don't trust yourself at all and you ignore it. It's weird, but you're right. That's how they teach us. They're like, don't pee, hold it. And you're like,
Yeah.
okay.
Yeah. So there's a question in the chat from Jacqueline. Some of the, well, actually, I think all of the suggestions that we had regarding sort of some of the group work were sort of for larger academic centers or hospitals. She's in private practice. What suggestions would you have to her for how she could start up some group meetings for her group?
I mean, I think that there's always groups of people somewhere. It might not be in the workplace. It might be somewhere else in the community. It might be a common interest, or, you know, we do women's writing groups now. I mean, I think that there are ways that you can still find that group of people to support you, even if it's not exactly in the workplace. But if you are connected through multiple practices, I am not going to tell you virtual's bad. Right. So the evidence is not convincing either way on connection and empathy. And we have tools now to do it virtually. And if that's what you can do, I think you offer it because it's better than nothing. And it's a way to connect and is a time to connect. I think one of the major things for me is like, if I don't have those things, I don't actually have a preserved hour for me or a preserved hour for those conversations. It just allows me to be in that time, even like, oh, that's on my schedule. I have to do it, right? And so I think it's important to like still use technology in those ways, even if it feels like it would be so much better if this was in person, like it probably would be. This would be better in person too, because I could get to hug you guys and stuff, but it is what it is. And we can still have those conversations.
Yeah, I absolutely agree. Seek out online resources if there isn't a local community group that serves your needs. There are a number of virtual, one of the ones that I really found useful is the narrative medicine group through Columbia University during the pandemic, just a space to look at a poem together for an hour and think about it and write in the shadow of that was a way out of my own head. Schwartz rounds can be found online. You don't have to join just at your own organization. There are many, many venues. I think even spaces like this through our professional societies are incredibly healing.
Thank you. One thing that we did at SIU that was very, very simple, and the goal really was community building. But we found the experiences to be very profound. We started what were called gathering tables, and they're very simple. Basically, someone would say, I will host 10 people for a meal on Friday. And then people would sign up. I can host 4. I can host 20. They were all different sizes. Some were formal, some were informal. One was like a cookout around a fire. And it was very profound, the conversations that happened. And so it doesn't have to specifically be that someone is suffering or that has expressed that they're suffering. It can be to really commune together. I've got 2 more questions that I'm going to try to get us to in 3 minutes. So one is from Lucille, and she says that she's writing a book. She talks about there used to be something called consciousness raising sessions in the early days of the second wave of feminism. She's writing a book and she's trying to find evidence of this for physicians, women physicians, and is finding very little. Wondering if you all have any thoughts or feedback for Lucille.
I don't know enough about that to say. I'm a bad feminist.
No, there's no such thing. No such thing.
I think Roxane Gay wrote a book called that.
I think you would probably see it more through organized like I think you'd see it more through like AMWA or other sort of women in medicine groups than you would in the sort of same way that feminism did it, because I think that is feminist for us, like to create women's spaces. And so you might just have to kind of redefine it a little bit, or say like these traditional ones are maybe don't exist to the same way in medicine, but in medicine having anything is different. And this is how we've tried to do that, and it's a little different. But I do think that we have spaces and we've created spaces, but they've had to be like these kind of spaces. So I don't know if the kind you're talking about, you're probably right that there's no evidence. We also are really bad about writing about things like programs, right? So sometimes people do really good stuff and you don't hear about it because it's at one place and they just do it and don't tell you. And so that's also a thing. So if there's people you can ask, that might be a person who like does those things. Digging into programming is hard, but necessary, I think.
Yeah, it's also hard to publish these things. There's not a lot of places that want to publish them. So this one is kind of a hard question to answer in 1 minute, but I'll let you two take a stab at it. Sally Ann mentions that a lot of time her colleagues will reach out about concerns, but they're not willing to really speak up. What can we do to create sort of psychological safety to allow people the opportunities to on employee engagement surveys, things like that, to share their concerns?
So I think when we think about creating psychological safety, I think some of it is the space in which it occurs, right? And the way that you can identify stuff. So surveys are not safe if there's one person that will be a certain demographic and they'll be identified. If that's the case, you shouldn't ask demographics. Even though you want to ask demographics for lots of reasons, you have to be mindful of how it might like limit who fills it out. I think in person, one of the things we do poorly is when we don't look at where we are when we're asking questions. We tend to lead with the thing the person is doing wrong instead of leading with some kind of like generalized statement or empathy, or, you know, I've been really tired from work. What's it been like for you? To see if they take the bait with open-ended questions, right? We tend to be like, hey, Rena, you haven't responded to an email in 3 weeks. What's wrong with you? And so what's going to happen is she's going to shut down and she's not going to either answer or she's going to get super defensive. She's not going to go, oh, that's a really good point. I have been really struggling at home. I guess it's coming out on my emails, right? So we have to be mindful of the way we're doing that. And the other thing I would just add quickly is we should avoid always problem solving. So we want to problem solve. I love a problem solve, but you know, I've had to learn even as a psychiatrist that my job is not just to problem solve. My job is to listen. And I think we neglect the power of listening and providing a space for someone for that. A lot of times in a culture as broken as medicine, we can't actually fix the things. And so you have to allow the space to listen, because you can say, here's why I can't fix the thing, but let's talk about it anyway, because I think that transparency will make people feel seen and understood, even if you can't give them that vacation day, even if you can't change that person who's being like the problem, right? So being mindful about not always problem solving is my other sort of big tip on there.
Yeah, that's a great one. Thank you. So I'm going to thank both of you. This could go on for a couple of hours, I'm sure. I know I would love it, but I'm going to turn things back to Dr. Sandhu to sort of take us home there. I did put one of the questions that we didn't get to into the chat. So if you two want to take a look, it's regarding students and how do they maintain empathy and in touch with their emotions. If you feel like answering that in the chat, that would be helpful. But thank you both so much. And Dr. Sandhu, the floor is yours again. Thank you.
Thank you so much, Sue. And thank you so much, Rana and Jessi. That was just an amazing conversation. Really appreciate all of your insights and your vulnerability. Incredibly helpful. I want to say thank you again to everyone for participating, for attending. This does conclude our program in celebration of Women in Medicine this month. Thank you so much to our visionary speakers for sharing your experiences, your expertise, your viewpoints on this really important set of topics. We're really proud to have created this collaborative relationship, and we hope you'll visit both the Women in Medicine Legacy Foundation website and the AMWO website. And I think you've got QR codes and web URLs right there on the screen. To learn more about both of these organizations, you can subscribe to the Women in Medicine Legacy Foundation, and we encourage all of you to do so, as well as to become AMWO members through those links. The QR codes will let you know also about upcoming events. One to be aware of, and coming up next month, October 8th at 4 o'clock Eastern, the Women in Medicine Legacy Foundation will be hosting their Alma de Morani, MD, Renaissance Woman Award presentation featuring this year's awardee, Dr. Myrna Weissman, who is an esteemed leader in mental health, psychiatry, and epidemiology. So please mark your calendar and plan to join for that Zoom event. AMWO does have events all month, pretty much every month, that will add to your career, to your support network, build friendships. Please check them out. I believe we will have, I don't know if there's a slide that will have the URL there, but perhaps Jody or Eliza, you might be able to put something into the chat. We also really appreciate gifts to both of our organizations. These are really impactful. They directly provide important programming, such as this discussion to our communities. We're very grateful to your support. And in closing, I wish to thank all of you for attending this program to honor women in medicine, and a very special thank you to our panel this evening.